here again to talk to you about HIT 292, healthcare reimbursement. We are still on Chapter 6. This is the second video for Chapter 6. We are on Week 11, and Week 11 is going to have 5 videos to it. This is number 2 of 5. We are on Inpatient Psychiatric Facility Prospective Payment System. If you are looking at your book, we are on page 128 at the bottom of the left-hand column, and we're going to pick up from there and move on. The learning objectives from the book are here on the screen, where we're going to talk about inpatient psych prospective payment system, how that works on the facility level and in terms of facility level and patient level adjustments. We'll talk about the provisions of the inpatient psych PPS and calculate how that works out. If you're interested or curious, make sure you take a look at the syllabus in terms of our unit objectives that we'll be working on this week, because that's listed there as well. So when we're talking about inpatient psych facility PPS, it's IPF PPS, and that's different than inpatient acute care PPS, that is IPPS. So just notice the difference in letters. Again, we're at the bottom of page 128 in your book. Facility level adjustments and patient level adjustments are what I want to talk about. But before I get there, I need to talk about the fact that this was implemented in 2005. Prior to this, inpatient psych facilities were exempt from a prospective payment system. They were reimbursed under TEFRA Reasonable Cost Payment Scheme. But since 2005, they have been under prospective payment. This includes psychiatric hospitals and psychiatric units in acute care hospitals. Again, they use the federal fiscal year, which is October 1st to September 30th, just like in inpatient acute care facilities as well. Per diem reimbursement methodology, that represents average daily operational, ancillary, and capital costs. This per diem rate is adjusted by facility and patient level adjustments to ensure adequate reimbursement. So what are those adjustments? Because I got started talking about them. On the facility side, it's wage index, cost of living, rural location, teaching status, and whether or not they have a full service emergency department. On the patient level side, it's length of stay, MSDRG with principal diagnosis of a mental disorder, comorbid condition, patient age, and whether or not electroconvulsive therapy was provided. I need you to know this slide very well because there will be questions on your quiz, hint, 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 about what is a facility level adjustment for IPF PPS and was a patient level adjustment for IPF PPS. So make sure that you are aware of these. All right, so length of stay, MSDRG, comorbid conditions, these are all patient level adjustments. In terms of length of stay, as it increases, costs decrease. Varying factors for the first day, higher for full ED service. So going back to this, if the patient came in through a full service emergency department at a teaching hospital in a rural location, they will be paid more. These are adjustments. Versus if someone just came in, they're not in a rural location, there is no teaching status, and they didn't come through an ED. There are 17 MSDRGs available for adjustment. And when it comes to CCs or MCCs, there are 17 categories that are applicable. And this makes sense if you think about it. And looking at page 129 in your book, the first day a patient is receiving inpatient psychiatric facility services is a very intense day. They're getting all their intake. They're getting their history and physical done. They're getting assessed by nursing. They're having a lot of tests run. It's a very resource-intensive day. As the days go by, that gradually decreases because the intensity is not there. They may still run some tests. They may still do some counseling and therapy and medications and all of that, but it's not quite as intense as it was at the very beginning. So that's why if you look at table 6.6 in your book on page 129, you'll see how that variable per diem payment adjustment happens over time. And then table 6.7 on page 130 lists the psychiatric MSDRGs that qualify for payment adjustment. On page 131 in your book, is table 6.8, where it lists the comorbid adjustment categories and what the factor is. As you can imagine, if you're dealing with a psychiatric patient with a tracheotomy, that is much more significant than dealing with someone who's not. Same thing when you're talking about artificial openings or cardiac condition or infectious disease. Those all complicate and may lengthen the patient's stay and the intensity of services that they're receiving. Age also has a slight adjustment to it, and that's on the bottom of page 131 on table 6.9. And then ECT treatments, that is an add-on payment, and here you can see the ICD-10 PCS codes for electroconvulsive therapy. Then we talked also about wage index, cost of living, and rural location. Those are on page 132 in your book. Cost of living is very different in Alaska and Hawaii. If you've ever visited there or if you know of someone who lives there, it's significantly different than it is in the 48 states here in the middle of the country. And still the wage index really accounts for a lot of that. Versus if you think about California, New York, Florida, well, not really so much Florida, but California and New York versus Iowa. Very different in terms of the wages and cost of living that they have. And that's where wage index and cost of living come in. And then rural location. Costs are 17% greater in rural areas. A lot of that has to do with economies of scale that don't happen. So this talks about in your book how this all works and needs to be accounted for in facility level adjustments. Additional ones are about emergency care patients receive or that's provided before they get there, and whether or not it's a teaching hospital. And we talked a little bit about teaching hospitals when we talked about inpatient acute care PPS. Same thing with inpatient psychiatric facility PPS. And one thing I want you to notice about emergency facility, it's the last bullet here at the bottom, the caveat. If the patient is discharged from an acute care hospital or critical access hospital and then is admitted to the psychiatric unit of the same facility, the ED adjustment does not apply. Notice that. But it's got to be the same facility, okay? Same facility. All right, some other provisions. High cost outliers, just as we talked about on the inpatient side. Inpatient psych also can have outliers that for whatever reason, maybe it's some of those complication comorbidities that the patient has that causes their length of stay to be higher or greater than expected. They may have higher cost outliers, and so there are add-on payments that look at that. And so it was 80 and 90% on the inpatient PPS. Here on the inpatient psych, it's 80 and 60, depending on the days. Notice that it depends on the days. All right? So moving on. Interrupted stay policy. What happens when they are discharged and they're readmitted to either another IPF or same IPF? If it's within 3 days, it's considered a continuous stay. And this is an example. So make sure you understand how they're calculating this, because there will be a question on your quiz, hint, 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 where you need to know this, that if it's less than 3 days, it's considered a continuous stay. All right, so now we're talking about payment. How is it all going to be paid? Let's take a look at this. Here is the calculation for the wage index adjustment. Because remember, Ohio and the Midwest, the rest of the Midwest, we are not considered one of those high, wild cost of living places. I am not going to make you actually calculate all of this out, so please understand you don't need to worry about that for the test, but you do need to understand what the formulas are behind it. So just make sure that you understand how they got to their numbers. And a good place to look at this is in your book, page 133, starting at the bottom of that, going over into the next page. Figure 6.9 is one that you really need to burn into your brain. Step 1, adjust for geographic factors, if applicable. 2, adjust for facility and patient characteristics. 3, adjust for daily costs and ECT treatment if they receive that. 4, adjust for high cost outlier if applicable. Make sure you know those steps. And remember, wage index, 75% is labor, 25% is non-labor. Make sure you know that. I'm not going to actually ask you to calculate it out, but you do need to make sure that you understand the reasons behind it, okay? Notice at the end of each chapter you have a review quiz. I will confess that sometimes some of those questions end up on the quiz that you end up taking. So if you study the chapter review quizzes, and I believe you can find the answers in your book. Let me double check that. Check your understanding. Those answers are in the back of your book in Appendix B. But if you can do the Chapter 6 review quiz and feel pretty comfortable about those answers, that will really help you when you get to your weekly quizzes that I put out there for your grades. All right, I have 3 more videos that are coming your way on Chapter 8 because this week, week 11, we're doing Chapter 6 and Chapter 8. So go ahead and get started with these 2 videos, and the next 3 will be here shortly. Take care and have a good rest of your day, okay?